Hey guys, almost rounding out our GI tract discussion here with some bowel medications. I'm talking about laxatives first. Constipation is something you probably come across in pretty much all medical specialties at some point. It's certainly common in inpatient as it is outpatient, and there are a ton of different over-the-counter options. Most of the options actually are over-the-counter. There's not as many prescription options, so patient self-care is a big has a big role in their own, as far as the patients making their own decisions. So education on the healthcare provider is good, just because you might get some people overusing laxatives or using the wrong types of laxatives for what they may need. There are some causes of chronic constipation here listed, and I'm not too concerned you know these, just know that there are some special populations that might have higher incidence. And then medications, something we should know about, of course. We've talked about analgesics, specifically your opioids, so I won't go into those again. You can see those down here. Probably the most common ones, anticholinergic medications. So those would be like most antihistamines, antispasmodics, antidepressants, and antipsychotics are all kind of the more common drugs that are used that have anticholinergic properties. Iron supplements is a big one too that is pretty common. And then some antacids contain aluminum. Those can be constipating too, so if you have somebody using a lot of aluminum antacid, that's intervention you can make there. So the overall effort here, we want to focus on keeping patients from develop some sort of dependency. So good lifestyle modification type things is important, advising to defecate after meals, and basically to take advantage of your body's normal postprandial increases in colonic motility and colonic activity usually being highest in the morning. Just the basic advice here is to have patients kind of listen to their own body and not hold in if they can avoid it. Dietary changes, fiber intake, fluid intake, and certain fruits and grains can be help the bowel tract to maintain a regular aspect. If the patient isn't getting adequate fiber in their diet, you can certainly supplement it. So there's some number of different fiber products on the market. They're all basically just insoluble stuff you're ingesting and adding bulk to your GI tract, and hopefully that bulk will help move things through and stimulate the colon to push things through is the idea there. There's a number of different common products on the market, Metamucil, Citracel. They're all just kind of variations of indigestible stuff. They're usually a powder. Some are flavored. There's tablets or wafers or lots of other things. Pretty much there's no evidence that says one fiber product is better than another, so feel free to recommend any fiber that the patient seems to tolerate. So if they find one more palatable than another one, that's fine. Again, there's not really any issue here. You can get some gas and cramping, so GI-related issues are what you're trying to correct here, but certainly you can kind of do the opposite too, especially if you overdo it a little bit. That can force some intestinal pain. So that's something just to keep in mind, but most people can take fiber supplements and probably aren't getting the recommended daily fiber, though it's not a bad idea to recommend somebody use some of these if they're having issues with constipation. Surfactants are probably the most common medication out there that people take first line as a laxative, and the reason is they're pretty benign. They basically don't do anything, and the only drug out there that's really used that still is, as a surfactant commonly is called docusate and brand name Colace. Its mechanism, basically it supposedly allows water to enter the stool by lowering surface tension, so it kind of again softens the stool that way by improving the liquid content in it. Doesn't really have any side effects that I know of. However, it also doesn't really work that well. There's a lot of evidence that says docusate doesn't really do anything, and it was actually inferior to bulk fiber in one review that was available, but most people don't even bother studying it because it's so widely used. It's like even if a study came out saying it's useless or equivalent to placebo, it's not really going to stop anyone from trying it. I think people like it because it's an easy intervention, it's cheap, it's harmless, and so if somebody wants to try it, you can't really go wrong with it. It's kind of like some of the studies out there for acetaminophen and pain, right? Similar concept. So docusate's really common. In fact, I say it doesn't really work, and the studies would say it doesn't work, but pretty much every hospital order set for an inpatient has some kind of a bowel regimen, and DocuSate's always on there. So it's like, every patient in the hospital has access to it. It's kind of funny that, we use a lot of things that don't have a lot of evidence behind them. This is one of them. But again, if you do get some benefit from it, the risk is extremely low. Again, you basically have no risk in giving somebody a surfactant, specifically DocuSate. So you can only have a benefit, really. So maybe it'll be an intervention that helps. But for most people, I don't think you can expect a ton with this. What we see it more often, well, commonly, I shouldn't say more often because it's used by itself quite frequently, but in combination with a stimulant laxative as well. So people think, well, the idea here is let's soften the stool. And we know that stool softening itself doesn't really move things through the colons or the bowel, so that's going to be a problem. So if we give something that can stimulate the GI tract to move things through, that can help us with pushing something through that's a little softer versus firmer. So there's that concept as well. We'll come back to stimulant laxatives in a second. Let's talk about osmotic agents. These are basically like poorly absorbed polymers, saccharides, other things. You kind of think of them like almost like the fiber concept on steroids. They basically cause water to pour into the intestine to create an osmotic differential there, so that the GI tract wants to balance itself by putting water into the intestine from the body. As you might imagine, if you use too much of this and don't replace fluids properly, you can end up with dehydration and electrolyte imbalances. So if you have a patient who has renal disorder or cardiac disorder, that's going to be potentially an issue just because of their fragile electrolyte balance state, probably to begin with. So we do want to make sure we're watching people. If you are going to give somebody a pretty aggressive regimen like a bowel prep, which is something called Go Lightly, it'll actually come with electrolytes, and so you're replacing some of the things that you're hopefully losing. It's not a bad idea if somebody's going to take Miralax on a regular basis to make sure that they're drinking plenty of fluids, and even supplementing with some kind of electrolyte thing, like specifically if they're at risk, like if they may be one of these renal or cardiac issues, or possibly like elderly patients or children even. Something like Pedialyte or a product like that contains electrolytes might be beneficial for them. But in small doses, these are relatively effective. Miralax comes as a powder, or is a polyethylene glycol. It comes as a powder. People take it daily or as needed. The one thing about as needed laxatives in general is that they take a while to work, and these drugs are no exception. I've got a table comparing them up here in a second. But as needed use is a little bit tricky because you might not get effects for 24 to 48 hours, or I should say more like 12 to 48 hours after you take a laxative. And so it's difficult to predict, making PRN use challenging. So a lot of times it's not uncommon to find people who take Miralax daily or in the evening, and then it helps them have a bowel movement in the morning. Go Lightly is Miralax or polyethylene glycol, essentially with electrolytes added to it. It comes in a huge jug that you use as a bowel prep kit. So it's like the typical colonoscopy prep, and all it is polyethylene glycol with electrolytes. There's some other osmotic agents that are synthetic disaccharides. These aren't the best option. We usually prefer polyethylene glycol. They tend to cause a lot of diarrhea. They work a little bit too well in that case, and abdominal bloating, just GI pain and distress in general. And so I don't see these used a ton. Sorbitol especially is notorious for causing pretty severe GI pain. Lactulose has some other uses. Basically, not to get into too much detail on it, but it has to do with exchanging ammonia. So people who have hepatic cirrhosis can't clear ammonia as well, and they end up with high ammonia levels, which can cause encephalopathy. And so you can actually use lactulose, and it pulls ammonia into the GI tract, so it gets excreted. That's really where it's commonly used, but it is technically a laxative, not really used as much for that anymore. So these ones, as far as a laxative drug, I wouldn't really put them on your list as something you'd want to use. They would work, but again, they aren't the most gentle of laxatives, and they just don't have a strong role in modern laxative-only use. Magnesium citrate is a pretty common one, and it comes as a liquid, so it's like a little bit effervescent. It's kind of bubbly, and it's just magnesium products in general have laxative effects. And milk of magnesia is another product that contains magnesium. And essentially, they're just magnesium products that don't absorb in the GI tract. They pull water into the GI tract just like other osmotic agents. Potentially, you can absorb a little bit of mag if you take this, especially if you're drinking a lot of it. And so for patients who can't clear magnesium as fast, like renal failure patients, probably want to watch out. But that's really the only population I can think of that would have an issue with magnesium citrate products. Usually these are a little bit, I think, tricky for patients to dose because you can buy this bottle over the counter. It's like, well, how much do you drink? There are some instructions on it for what to do. But you will see this used as a colonoscopy prep adjunct. So sometimes they'll give them the Go Lightly, like the polyethylene glycol kit plus a magnesium citrate bottle. This is my joke for today. I don't know if this link even still exists, but there's these gummy bears that were made with something called lycosine, which is a sugar alcohol. Sugar alcohols are essentially non-soluble saccharides that have pretty severe laxative effects, and so there's a whole string of reviews that were going around the internet, and there were people getting pretty creative describing the symptoms these gummy bears caused, and so it was a little bit entertaining there. I don't know if the link still works, but I'm sure you can find it if you Google it. All right, moving on to stimulant laxatives. So these are actually going to force the GI tract to move things through. So these are really popular just for that reason. And they essentially work by altering the way electrolytes are transported by intestinal mucosal, so across the intestinal membranes, and that will trigger in some sort via a number of mechanisms in intestinal motor activity, and by doing that, push stool through. Bisacodyl and Senna are the two drugs here. Bisacodyl is a tablet and suppository. It's very potent. I think actually somebody corrected me on this a few years ago. That's not prescription only. I think you can actually buy a lower dose suppository over the counter. But anyway, the point is that this is one of the most potent laxatives we have, and it's something that is usually reserved for people who haven't had a bowel movement in several days, especially the suppository. When it comes to laxatives, I said that it takes a while. Well, suppositories, and specifically bisacodyl suppository, is really the fastest acting laxative you can have. So if you really haven't had success with other things, know that one's at least going to give you some quick results if it works. Senna isn't as potent as bisacodyl, but that actually might work to its advantage. It's probably one of the more popular choices out there, and Senna Plus is a combination of Senna with docusate, and that one is, again, probably one of the most commonly used inpatient bowel regimen things. It does take a while for Senna to work, but it is relatively effective compared to just docusate alone. Here's your onsets, and that's really the only reason I have this. There's some other interesting information here, but I just want you to take away the general message that nothing works quickly when it comes to oral laxatives. So pretty much anything on here that's oral isn't going to work fast. The only thing that has some speed to it, where is it? Magnesium citrate can work in a couple of hours, and magnesium sulfate. So magnesium products can work a little bit quicker than other things. Otherwise, you're talking about mostly suppositories here. And look at polyethylene glycol. So here's Miralax, 1 to 4 days. So again, taking that as needed, it's like, well, by the time you take it, it's like you still have to wait a fair amount of time for it to actually start working. So it's tricky to manage laxatives with as needed regimen. That's why a lot of times with people who are on something that chronically constipates them, whether it's some disease state they have or medication they're on, it's important to stay on top of the bowel regimen, to schedule it and make sure it's regularly being taken. Otherwise, it probably isn't going to work or be very effective. A couple of newer agents on the market. These ones are prescription only, so kind of shifting away from the mostly over-the-counter remedies. These are chronic idiopathic constipation agents. So 2 drugs on the market, linaclotide and lubiprostone. Linaclotide is a minimally absorbed peptide agonist. It's tested in fluid secretion and transit, so it sounds familiar, right? These are the way the other drugs work mostly, but this one just kind of does both. It pulls water into the GI tract and also stimulates transportation, or transit, I should say. I don't know if that's the right word. Dosed once a day And these are both brand only. They're both pretty expensive, especially compared to the other agents we just talked about, which are all over the counter for the most part. Even Bisacodyl, that's not, is relatively cheap. It's been generic for a number of years. Lubiprostone is a locally acting chloride channel activator, and that's just going to cause fluid into secretion into the intestine that's chloride rich. I'm not sure if chloride rich matters really, and the fact that it's just promoting fluid moving into the intestine. So both of these work very similarly, but they have different mechanisms, so people might respond better to one or the other. For really severe constipation, something rectally administered is going to be faster than something oral, so a suppository or an enema will work the fastest. We've got Bisacodyl, glycerin suppositories. Glycerin suppositories are much more commonly used in children because glycerin is really pretty benign when it comes to any types of side effects. Bisacodyl can be used in kids. Really, most of these things aren't going to get absorbed systemically, so you don't really have side effects to worry about. Mineral oil, saline, and warm water enemas are recommended to varying degrees. They usually don't have a preference, and I don't see these used all that much. Sodium phosphate enema is Fleets. So Fleets has complications in elderly in patients with renal issues because it is phosphorus, and if we are absorbing extra phosphorus and not clearing it, that can cause problems, as we talked about last fall at the end during the renal lectures. Hyperphosphatemia is the big thing to worry about, but for healthy patients, you don't have to consider it. Hypotension, hypo and hyperkalemia, renal failure, and EKG changes are the other things that would maybe be seen with hyperphosphatemia, but again, you aren't going to see that in a person who's healthy or doesn't have kidney issues. One thing that I didn't put on my slide, but that I'll just mention that is somewhat popular, is something called a pink lady, or sometimes people call them pink elephants. It's essentially an enema. And it's a combination of Fleets, but we add a few things to it. We add liquid docusate, mineral oil, and magnesium citrate. So you're combining like 3 of the things we already talked about with the Fleets enema and then instilling that rectally. And that's something that I see used in the ED a fair amount. Hospitalized patients usually, because it's not something that somebody can just get. You'd have to be able to make this over the counter. You could easily make it actually, because all those things, with the exception of, I'm not sure if you can get docusate liquid over the counter. If they sell that, they might, but most of it you could make, and it's essentially just using a kind of a super enema that's a combination of a number of different drugs. But you might see that ordered sometimes. It's something that most pharmacies specially make, so when we get an order for it, we actually mix all the stuff together. There's no commercial product. So just know that it's a little bit more time intensive to do something like that, and I'm not sure if there's really proven benefits behind it. So something to consider, but you might see that order and be like, what's a pink lady? Well, that's what it is. Why it's called a pink lady, I don't know. My friend who works at Children's says they call them pink elephants over there because the tube to the enema, when it fills with liquid, the docusate is pink, and so the elephant looks like an elephant trunk, I guess. I don't know. Try and make kids happy who are getting enemas. You come up with weird things like that. A couple other options that may or may not be used. Again, I highly doubt you're going to use this kind of stuff, but maybe. Misoprostol is a prostaglandin analog. It's used with polyethylene glycol. I've never seen this used for constipation or for as a laxative agent, but it's technically an option. It's more commonly used in OB, and we'll talk about that then. Colchicine has laxative effects, but usually used for other things. However, it may be effective for this particular instance if nothing else is really working. Botulinum toxin would really be only used for patients with different types of muscle spasms causing their constipation, and that would be a very specific group of patients. So basically spinal cord injuries or patients with some sort of neurologic or some sort of nerve muscle damage, and it's quite expensive. And then colectomy, which we don't need to talk about that here. It's not part of our scope. So really looking at the basics, we're addressing the underlying problem. If there is something we can address, if not, if nothing seems obvious, the basics are important. So diet, hydration, fiber supplementation, osmotic and stimulant laxatives plus or minus a surfactant are going to be your first line choice. And then if you need something else, the newer agents, lubiprostone, would be something to consider. Otherwise, Botox or misoprostol, depending on situationally useful. For a really impacted bowel, that's kind of, I would refer you back to the enema slide. That's sort of going to be the more emergent type option. You're going to use rectal formulations and enemas and maybe even the pink lady if you decide to go down that road. All right, switching gears here to treating diarrhea instead of causing it. Here's my little linguistic lecture for the day, derived from the Greek to flow through. Makes sense, right? You need to assess the reason, acute, chronic, infectious, medication-induced, illness-related. All those things can lead you down the correct pathway to treatment here. So I'm not going to talk about infectious disease really, or test you on that again. We already talked about that. So food poisoning type issues, stomach flus, norovirus, whatever it might be. If you're suspecting infectious disease, remember stool culture and then treatment. So initial treatment is usually going to be oral rehydration and supportive care, most likely. So something with a little bit of calories might be good for the patient, and specifically something with electrolytes. So like a sports drink like Pedialyte are ones that are usually recommended for people with some sort of a acute onset of diarrhea. IV hydration can be done in severe cases, but usually isn't necessary. And we talked about stool cultures. And viral infections can't be treated. They're short-lived. Our bacterial stuff we talked about last fall, most are self-limiting, but there's some options out there that I won't rehash here. Diet, I got some crap for talking about this from a former dietitian who took this, who was in this class a couple years ago, and she made fun. I don't know. She basically said the brat diet isn't a real thing, but I was taught this in school, so now I'm going to teach it to you. Now, I think that the point in this slide isn't that the brat diet or brat or however you want to say it is the only thing you can take, but basically introducing diet at a rate that's appropriate for the patient is important. So if you're at a loss for what the patient could eat, I think this isn't a bad way to remember what types of food are more mild or bland that pretty much the general population can tolerate. So this is, if you don't know what that stands for, it's bananas, rice, apples, and toast, all pretty bland stuff. Now, there are the dietitian who was in the class was actually absolutely correct that basically if you can tolerate it and you're doing okay with it, if you feel like you want to go out and eat a Chipotle burrito, I'm not going to disagree with you on that. I've certainly had bouts of GI bugs or like a stomach virus or something like that, and then by the time I feel better, I'm really hungry and want to eat like everything in sight. So sometimes, it just depends on the person. But if you're looking for ways to introduce things gradually, it's not a bad idea to kind of keep in the back of your head this type of stuff. It doesn't have to be these 4 things exactly, but certainly that's a nice way to start and think about what you have at your disposal to have somebody eat. It's going to be the least likely to cause issues, put it that way. Symptomatic therapy. So we have a couple options here. So these came up on the last lecture. I apologize for the question on there. I definitely told you not to know this, and then I asked you a question on it. So I did throw out that question. It didn't count for or against you. So that one was taken out of the exam count total. Now we'll come back to them, and I'll probably ask a similar question on this next exam, so it's probably good for you to know it. But let's talk about loperamide. Loperamide is going to be the more common one. It's over the counter. It's easily accessible. It works to a certain degree. It's an opioid receptor agonist. It doesn't really absorb systemically at all. There's really not a risk of abusing this, even if you ground it up and injected it. I don't think it really does anything. Diphenoxylate and atropine, or Lomotil is the brand name, is really the same concept as loperamide. It's not over the counter. It's prescription. It's a controlled substance, and it may have some systemic opioid effects, which is why they mix it with atropine. So if you inject it, you don't get a pleasant experience, I guess. It's like a control 4, or I can't remember if it's a 4 or 5. Anyway, it's not a high control status, meaning there aren't a lot of risks for abuse out there. But basically, if you're going to treat somebody, you sort of follow this algorithm. I'd start with loperamide because anyone can find this. It's cheap, might be effective, might not be. The dosing on it's basically you take it to a certain amount until you produce the effect you want. And there's not really a well, there is kind of a ceiling dose to it and a recommended total daily dose, but it's like with any opioid, there's tolerance levels, and sometimes the thresholds of those are limited based on side effects. And in this case, there's really not systemic side effects, so you could keep giving it. Just be careful not to overdo it in somebody. Ultimately, if you need to use opium tincture in somebody with severe, like chronic diarrhea, that is done occasionally, but it's not something that's very common at all. One thing to consider about any opioid therapy is that fluid may pool in the intestine. So your oral fluid intake should be aggressive. So you want to give your body the ability to flush things through, even though you're essentially stopping the GI tract from moving. You want to find that balance in there, but that can be difficult sometimes. If somebody has fever or dysentery, obvious signs of infection, you want to avoid these agents, and that's because of this component right here, this fluid pooling. You don't want the bacteria or whatever's in there causing the issues to be sitting in there. You want that to get flushed out of the system as best as possible, so we try to avoid this. However, if the symptoms are bad, does a dose here or there make a difference? It's difficult to say, but you certainly don't want to paralyze the GI tract and slow it down. So usually it's recommended to best stay off of any type of opioid if you're trying to clear the GI tract of some sort of infectious disease. Pepto Bismol is bismuth subsalicylate. It's not a super effective medication. However, it does have some anti-secretory and antimicrobial activity, and maybe some even anti-inflammatory effects due to a salicylate moiety, which is going to have kind of aspirin or NSAID-like effects. It does get used sometimes. They're recommended for travelers' diarrhea prophylaxis. I think I talked about this last fall a little bit, but to use it correctly, you have to take it with every meal. The evidence is really scant on whether it actually does anything or not. Personally, I don't think it's worth the hassle, but some people swear by it when they travel to places that maybe have not great water supply or don't really have control over what their vegetables are being washed in. If you do recommend this to somebody, like if you have a patient that's going out of the country and they want to try something like this, just know that it can darken the tongue a little bit. It can also cause somebody to see grayish black stools, which is also something somebody might think of as in terms of having a GI bleed. So just make sure that they understand that that's a common side effect with this, and that's the basics of taking it every day. It's what's going to happen. Contraindicated in pregnancy and children. That the salicylate moiety is possibly linked to Rey syndrome, just like we talked about with aspirin. Probiotics. I had a friend in school who always told me, like, well, if you're on an antibiotic, you should be on a probiotic. It just makes sense. Like, yeah, it's not really that simple. Probiotics are probably effective, and I say probably because there's really not a lot of good information out there, and the information that is out there is all about mild cases of diarrheal-related illness. There's not any good information about severe illnesses, and there's certainly no information that says probiotics help if somebody has C. diff or something like that. However, probiotics have no consequences to taking them, really. So if you're going to take a probiotic, certainly I'm not going to judge you for that. That's fine. Certainly there's dietary intake sources like yogurts and things like that you can take as well. The different types of bacteria are listed there. There's certainly lots of other things that can be in these products too, various other yeasts and bacteria that I'm not listing, so certainly not an inclusive list. I think it's come up recently that certain probiotic packaging, as far as the capsules are designed in, get destroyed in the stomach. And so if you take a probiotic, you just kill everything. I don't think that's absolutely the case. I think a lot of times the capsule will be designed to at least somewhat get through the stomach, or some of the bacteria will get through the stomach. Yes, your stomach's good at killing bacteria, but people have been using like these types of products here for years and millennia with good effects. And some people think that the dairy component of yogurt or kefir or kombucha or whatever they're making out of it, and kombucha is not dairy, obviously, so let's just use yogurt as an example, that the dairy product actually kind of buffers the bacteria in the stomach, so some of it can get through. So certainly there is plenty of bacteria that probably gets to the site, so I wouldn't really worry about fancy marketing tactics to say that certain things don't even get to the site and they need to be packaged in a way that allows them to survive the stomach. I think that's a little bit silly, but that's my take on it. All right, prokinetic agents, if you want to just get the GI tract moving. Gastroparesis is delayed gastric emptying. You don't have any type of obstruction. Your symptoms could be any of those things listed. And there's a couple different other things here. Usually we're looking at some sort of a drug that is prokinetic, and a lot of times antiemetics come into play either as prokinetic agents themselves or as symptom control as far as anti-nausea. So metoclopramide or Reglan is our antiemetic agent we've already talked about, but it's also a decent agent that promotes motility. It's the first line for gastroparesis. It's relatively well tolerated, and it works pretty decently. The other options we have are macrolide antibiotics. So erythromycin, I think I mentioned this very briefly last fall, but erythromycin is not really used for any type of infectious disease anymore. It's pretty much used just because it agonizes the peptide hormone motilin, which causes a motility increase in the GI tract and contractility. It's dosed pretty regularly. It comes as a PL liquid and IV and capsules, but the PL liquid has actually been shown to be the one that works the best for this. IV would work too, but that'd be really odd to do that. Problems: erythromycin is not a great tolerated medication. It causes it's notorious for tachyphylaxis, meaning it stops working after being used for a while. It causes GI issues, which is what you're trying to do, but it also can cause more pain and more harm than it's good. Bacterial resistance is a problem as well with using this regularly. Azithromycin would do the same thing, but it would rarely ever be used for this particular indication, but it would cause GI, it would cause the same effects as erythromycin. Other approaches, antiemetics aren't prokinetic, but they'd be for symptom management, as I said. Some medications that are anticholinergic, like tricyclic antidepressants, would be an option too. We'll talk about those during psych more so, but that's really all I want to talk about. The main drug here would be metoclopramide, and then maybe you might see erythromycin oral liquid used occasionally, but that's pretty much it.